So let us talk about how to manage bleeding angioectasia. So when you perform colonoscopy and you don't find a source for bleeding and the patient keeps bleeding and you can't find the angioectasia, sometimes it helps to give an antagonist to morphine like naloxone, and that opens up the blood vessels and makes the angioectasia prominent. So that is something to keep in mind. And it's also important to make sure that the patient has adequate amount of hemoglobin. And if you perform an endoscopy without adequate resuscitation and the hemoglobin is low, sometimes these angioectasia don't fill up and may not show the uh, it may not be obvious to the endoscopist. So important to resuscitate well, and also if there is a doubt, to use uh, reversal for opioids. Here is an angioectasia in the right colon. Angioectasias tend to have a feeding vessel, and these could cause bleeding. I would like to share with you what I do in my own practice about managing bleeding angioectasias in the right colon. So I try to inject epinephrine 1 in 20,000 dilution, about 1 ml, and wait for a few seconds. And what will happen is most of these branches will disappear and you will see the central feeding vessel. And that's what I do target with my APC probe. And I set a very low wattage, 15 watts, and a low flow rate, zero point 0.8 liters per second, and zero point 0.8 liters per minute, and then apply very short bursts for half a second to 1 second bursts. And that's going to ablate the feeding vessel, and that will allow the angioectasia resolve. So important to uh, try to hit the feeding vessel. And since these patients are tend to be older and they tend to have a thinner colon, although it is not a routine practice that is employed by others, after the ablation, I always clip close the defect so as to prevent any delayed risk of perforation. I want to share something that is very important. That is angioectasia. I've seen where people have applied APC at a high power setting for a prolonged period, and that tends to cause deep thermal injury, and it could lead to delayed perforation. And uh, if you're not serious about the patient's complaint, so the patient goes home and then a day later they may call and say, I'm having some discomfort, and you should be worried that this is a post polypectomy deep thermal injury syndrome. And if you do not manage them by bringing them to the hospital with IV fluids, antibiotics, and close observation, and keeping them nil by mouth, the wall may perforate. And the perforation among all the different types of colon perforations can be nasty, lead to peritonitis, and these patients perforations cannot be closed as they tend to have quite a bit of fecal peritonitis. So for these reasons, uh, given the fact that organ plasma coagulation without injection into the submucosa, the injury could go deep into the muscle, cause post-polypectomy syndrome and delayed perforation. I share with my fellows that it is important to inject uh, into the submucosa, and if you put a dilute epi, it will cause spasm of the branches and shows up the feeding vessel, and instead of treating the whole area, you treat the vessel that is bleeding, that is actually feeding that angioectasia. So with a little amount of cautery, you're going to achieve hemostasis. You would avoid the risk of using a lot of cautery over an extensive area and risk perforation. So very important to keep this thing in mind. Keep in mind that you want to inject before you apply organ plasma coagulation. Keep in mind that you want to resuscitate the patient well, make sure that they're hemodynamically stable, their hemoglobin is a decent amount, and if need be, you may want to give some naloxone to reverse the effects. Even if you're not giving narcotics, giving naloxone can show up these angioectasias. Thank you.